sir, we are live.
So, good morning, respected faculty and dear delegates. And we welcome Dr. Suresh Gupta, head of the emergency care at Sir Gangaram Hospital, and Dr. Sandeep Dhingra. I also welcome Dr. Shyam Meena, Secretary, IP Delhi. I request Dr. Shyam Meena to please take it.
Hello, good morning, everyone. Welcome to all our chairperson and speaker. Good morning, Dr. Samir. Good morning, Dr. Bharat. Good morning, Suresh sir. Warm welcome on behalf of Indian Academic Pediatric Delhi IP State. Thanks to Dr. Maninder for design this wonderful program. I think I joined this some couple of minutes late. We can hand over to Dr. Maninder to start the program.
I request Dr. Veena Raghunathan to please take over and introduce the chairpersons and the speaker.
Thank you, sir. Today we are honored to be joined by distinguished speaker and moderators. Speaker for today is Colonel Dr. Sandeep Dhingra. He is a pediatric intensivist presently posted in Srinagar. He's an alumnus of the AFMC, prestigious AFMC Pune, and he is a pediatric intensivist. He's a seasoned clinician, teacher, and an academician. He has been instrumental in establishing the pediatric critical care services across various armed force centers, and he has extensive experience in emergency medicine as well as toxicology. So Dr. Sandeep, thank you so much for joining. And the moderators of today's session are Dr. Suresh Gupta, sir, who really needs no introduction. He is Director, Pediatric Emergency and Intensive Care at Sir Gangaram Hospital. Sir is a pioneer in the field of pediatric emergency medicine, trained from Albert Einstein University in USA, and he has a vast experience in managing complex pediatric emergencies as well as training many emergency physicians as well as intensivists in this area. Thank you so much, sir, for taking out time on Sunday morning. We will also be joined by Dr. Bharat Chaudhary, who's presently probably in the flight. He's additional professor and pediatric emergency and trauma at AIIMS Jodhpur. He may be delayed in joining, but welcoming you all and handing over to Dr. Sandeep for starting the session. Thank you.
First of all, my sincere thanks to Dr. Veena for such a kind introduction and to this opportunity to take this important topic and spreading awareness about pediatric poisonings. I must acknowledge I am a student of Dr. Suresh, and it's my privilege that he is moderating the session. And without much ado, I'll begin with my presentation. Let me start sharing my screen. Is my screen
Yes.
visible to everyone?
Yes, yes.
Okay. So the topic for today will be approach to a child with poisoning. And I think this is a topic which is actually so broad that it is very difficult to cover in 40-45 minutes. But then what I'm going to focus upon are the principles and the approach to a child. And I'm not going to delve into individual poisons because then it becomes too vast. And because the principles remain the same, the diagnosis of the poison which the child would have ingested or exposed to can be found out in the next 12 to 24 hours while the patient is with us. So I bring greetings from my hospital, and just to share the overview with everyone, I'm going to cover my topic in next 40 to 45 minutes under these headings, which will be introduction, common poisonings and toxidromes, basic approach to management, indications for admission, especially to the PICU, and elimination techniques, which we all must know because we should not waste any time in first of all deciding and then taking on the elimination technique which will be the most suitable for the child, and how to prevent, basically to spread awareness that we don't get such patients very often. So like always, I would like to begin with my personal experience. It was a Sunday like today and like I'm talking about duty which I was doing on emergency duty on Sunday in Gangaram Hospital around 13 years back, when a 6-year-old child was brought with altered sensorium, vomiting, and there was a history of clearless fluid ingestion, which was stored in an empty disposable water bottle. And the child just took one sip and he felt dizzy, unconscious. And these were the vital parameters which we recorded: heart rate of 138, the respiratory rate was 26, and SpO2 was 46%, GCS was 11, and pupils were equal, round, reacting to light. Now, this was the kind of breathing the child was having, and I was alone in the emergency, and the parents were staying close by in Karol Bagh only, Delhi, and the family was going from one place to another, and the mother was crying incessantly because this was their only child, and she said कि हम लोग जा रहे थे अभी to a mandir in early in the morning, and it was around 10 o'clock when the patient arrived in the ICU. So now this was the child, and one can see the face. He was drowsy and comatose, and his breathing was labored, and his SpO2 was 46%. So then we went ahead with the diagnosis. So we did some testing. So hemoglobin was normal, WBC was normal, electrolytes was normal, liver function test and and renal function tests were also normal. So because the saturation was so low, we did an ABG, arterial line was placed. And when I took out the arterial blood, it was chocolate brown in color. And the clue was that the history, then we asked for the social history and found out that the father used to work in a printing press. And the clearless fluid, which was there in the bottle at the rear seat, because it was summer months and the child was feeling very thirsty, so he thought that it is water which is kept, but then it was fixer. There's something a chemical which they use in the printing press was fixer which was kept. And when we did a co-oximetry, we found out that meth hemoglobin was 31.27%. And these are the real pictures of the ABG which we took on that day. And then over a period of time, the meth hemoglobin level came down, and the pH was normal, like more towards the alkaline side. CO2 was 20, and this was respiratory alkalosis because the child was hyperventilating. And what one can also see is the O2 was 206. So though we were giving oxygen and oxygen partial pressure was 206, still the saturation of the oxygen was 61%, and the meth hemoglobin level was 31%. So had we not had the co-oximeter with us, we wouldn't have gotten diagnosis. So these are the few signs and symptoms of whenever the methemoglobin level rises. So he was in this range, 30 to 50%. He was having tachycardia, breathing difficulty, giddiness, exhaustion, headache, and uh, he was unresponsive. And over a period of time, we gave the antidote, and the methemoglobin level came down to 3%. Less than 5% is normal. Like we were okay. And the proof of the pudding that the patient is getting better is the urine, the green color urine, the greenish blue color urine, which came out when we started giving him infusion of methylene blue. So I must tell you here again, I'm sharing something that that day we didn't have methylene blue in our ICU, and the parents had to run to various hospitals. I spoke to around 5 hospitals, and none of them had it. Then there is one shop in Connaught Place, the Nath Brothers, from where we got 5 vials of methylene blue and we could start the treatment. So, how important it is to keep some common antidotes in the ICU. That learning I still hold with me and will be sharing with everyone. So we had to ventilate this child with minimal pressure settings because the lungs were normal. The patient was hypoxic in spite of oxygen. Repeat doses of methylene blue were required. Saturation became above 92%. He developed anemia maybe because of this thing, because of hemolysis. And we also had to give vitamin C and NAC. Extubated. G6PD was normal. So to introduce the topic, now coming back to the topic, pediatric poisonings are the most frequent medical emergency, which we, after the respiratory emergency, which we see in the emergency department and can be up to 5 to 7% of all visits. Now, 50% of all toxic exposures in children are because of poisons. And luckily, in our country, 80%, approximately 80% are unintentional. And out of these patients who come to the emergency department, around 10 to 15% need ICU care. Now, like I mentioned earlier, there are plethora of routes and variety of poisons, and it is really very difficult to keep a track of all of them. And what we have also seen is there is usually a bimodal peak because of the various instincts which the child have in less than 5 years, and usually it in children who are more than 13 years of age, it is intentional. There is a national poison data system in America, and the only data which we have from them, the international data, shows that around 45% are less than 5 years, while in their country, more than 13 years constitute around 8.2%. And the mortality is very high because it is an accidental exposure. So mortality is pretty high in spite of the best of management. And the five leading toxins which remain common to us also are the personal care products, which constitute around 11%, then house cleaning substances, then we have analgesics, uh, toys and foreign bodies, then dietary supplements. This toys and foreign bodies has suddenly increased in our country. And in my last around 7 to 10 years of experience, we are getting a lot of foreign bodies ingested, which constitute the toys and foreign body. Then dietary supplements, herbal and homeopathic medications, especially if left unattended by the parents, also constitute one of the leading toxins which the children are exposed to. When we come to the Indian scenario, we have a National Poisons Information Center, which gets around 900 calls per year. And out of this, more than one-third calls are for children age group of 1 to 18 years. And like the Western data, even in India, kids up to 6 years are the most vulnerable, while children more than 13 years account for around 8 to 10%. Accidental remain 80%, and intentional around 20%. This study was published by our own Dr. Suresh Gupta many years back. So when we talk about the routes, there could be a oral being the most common, but then we have ophthalmic, inhalational, parenteral, and dermal routes. So it is not necessary that we only ask the history of ingestion. We must also undress the patient and also look at the eyes. And in case there are any IV or IM, especially in deliberate poisonings, we must look at IV sites, common IV sites, and look for the injectable sites also. Presentation is totally diverse. I will just cover a few toxidromes in my later slides, but then it is really very difficult. Uh, to find out the toxin based on the, we can find out about the toxidromes, but individual toxin is very difficult to identify. And most of the patients come with non-specific complaints. So we have to spend a lot of time on history and examination. But then there are a few vital questions which all of us must note down, jot down in the case sheet, because we cannot revisit the patient, ask them. And these vital questions remain, that what is the agent? Like in the case which I mentioned, though we didn't know what the agent was, but then we got a fair idea that because the father is from the printing press industry and the chemical was a fixer, so we could generally Google up and find out what it can do to the patient. Then form and route of exposure, when and how much. Now, this is a very important question because when decides what is the decontamination technique which we are going to use. So this is a very important question, and we must note down the exact time when the patient has taken or has been exposed to the poison, and how much, like even one gulp, or because again, the decontamination technique and what amount of antidote which we are going to use depends on how much the poison has been ingested. Then what were the symptoms, like whether it induced the vomiting, or there was some hemorrhagic symptoms, or the patient became drowsy, comatose. We must, or were there any seizures which the child developed, and what was the temporal sequence of these symptoms should be noted down. Then any intervention which has been done, because most of the time the patients don't come directly to a tertiary care hospital. We must know what the parents have tried doing, so that we can, add on to that. And any chronic illness and medication intake which the child is already on, just to note down the effect of the poison along with the medications. So after the history, we must undress the patient, look for signs of spillage, especially around the perioral cavity or on the body. Look for IV sites. Look for envenomation, because many times we feel it's a poison, though it could be a snake bite or a scorpion sting, or sometimes even a spider can lead to envenomation. We must always look for evidence of child abuse, because if the child is in coma, he may not be able to tell us that it's accidental or deliberate. And examine the skin mucosa, pupils. Especially, we have to endorse whether the pupils were equal, round, reacting to light. And CNS and autonomic nervous system examination, like we do in advanced life support. And note down the constellation of findings based on the various toxidromes, which I'm going to cover shortly. So, along with initial assessment, we must also look at the vital parameters. SpO2 is really very important here. Examine the mucosa and signs of drug abuse, especially in older children, or like 14 years plus. Eye signs, pupils. One must also look at abnormal odors, because sometimes alcohol and any acetone, exposure to acetone, methanol, all these odors should be noted down, and note of the consciousness. So coming to the toxidromes, the common ones are the stimulant or the sympathomimetic toxidrome, in which the patient is hyper alert, agitated, restless, and he's thrashing in the bed, which we must have seen, and the pupils are dilated. There is insomnia, the skin is hot, there is tachycardia, tremors, excessive motor activity, and the various agents are the ADHD medicines, amphetamines, cocaine, and other stimulants. While there is another toxidrome which is sedative or hypnotic, in which there is confusion, sedation, stupor, delirium, and the pupils are like normal in size or can be both mid-dilated or mid-constricted. There is blurring of vision, diplopia, nystagmus, slurring of speech, ataxia, and this is caused by benzodiazepines and barbiturates. And then is the opioid toxidrome, in which the patient comes in coma and CNS depression, and the pupils are especially like fentanyl and other agents in this category, in which the pupils are constricted. The patient is in hypothermia, unresponsive, bradycardia, bradypnea, shallow respiration, hypotension, and decreased bowel sounds. Narcotic agents, heroin and clonidine are the common uh, poisons. Then we have the anticholinergic and cholinergic syndromes, especially with the organophosphorus poisoning, in which there can be agitation, hallucination, delirium, coma, and the confusion coma in cholinergic. But the best thing here is that if we see the pupils, if they are dilated, then it is anticholinergic. And if they are constricted, then it is cholinergic. Symptoms remain more or less the same. Fever, tachycardia, flushing, dry skin, urinary retention, blurred vision, ileus, seizures, myoclonus, hallucination, psychosis, and coma. While in cholinergic toxidrome, we have this mnemonic sludge. So in which we have salivation, lacrimation, urination, defecation, GI distress, which we call as diarrhea, and emesis. Positive agents are antihistamines, antidepressants, popolamine, sleep preparations, and mushrooms. While in cholinergic, we know it can be organophosphates, carbamates, insecticides, spiders, and certain mushrooms. So we must remember these toxidromes, the sympathomimetic, the sedative, the opioids, and the anticholinergic and the cholinergic. These 5 toxidromes, we must try and find out whether the patient is fitting into any one of them. Now, to fit into one of these toxidromes, though we have to examine the patient and all the systems, but there is one examination which we normally skip or do very cursory, but here we must do it in detail, is the CNS examination, where we must look at the plantar reflex and the deep tendon reflexes and the tone. These are the 3 very important uh, assessment in CNS examination in which we must do. If excuse me, if we have extension, brisk reflexes along with hypertonia, then we call it a pyramidal syndrome. And then we can, especially the carbon monoxide, the sedative antihistamines, phenothiazines, antidepressants, and the hypoglycemic syndrome, in which if there is pupils are constricted, then we can think of organophosphorus poisoning, barbiturates, clonidine, and phenothiazines. But in case the pupils are dilated, then we can think of atropine, tricyclic antidepressants, ethylene glycol, and methanol. If they are normal, these 3, then it can be extrapyramidal syndrome, in which benzamide and butyrophenones can be the cause. But if the reflex is plantar and the flexor plantars or the DTJs are diminished and the patient is hypotonic, then it is called the myorelaxation syndrome, which can be because of the sedative hypnotics, benzodiazepines, zolpidem, phenobarb, phenothiazines, opioid poisoning, and ethanol. If we have nystagmus, we must think of anticonvulsants, quinine, solvents, alcohol, hypnotic sedatives. And we must also remember that pupillary light reflex is usually preserved in structural coma. And we must always keep, whenever the pupils are reacting to light, then we must think away from the poisons, and we must think about any structural causes in because of coma, which may be meningitis or head injuries. So coming to the emergency management, and if by this time we have been able to fit in our patient into one of the toxidromes, then we can think about the emergency management, and the principles of emergency management actually remain the same, whichever poison the patient may have been exposed to. So because it is a multi-organ pathophysiology, the first and foremost remains resuscitation. Second would be decontamination, and third would be supportive care. And we all know when we talk about resuscitation, it is basically stabilization of the ABC, airway, breathing, and circulation. Here, I would like to add DEF, which in ALS used to be a mnemonic DEFG, which is don't ever forget glucose. Here, DEF is decontamination, elimination, and ECG, and F is fever. So, A is for airway, which includes airway adjuncts, use of oropharyngeal airway, nasopharyngeal airway, or in case required, intubation, or a surgical airway, especially in poisons because of ingested poisons which are corrosives, especially acids and alkalis. Then breathing, we may have to give ventilatory support. We should not give ambu bagging for long. It should always be less than 2 minutes. Then in circulation, we may have to give fluids and inotropes. We may have to start oxygen. And DEF is whenever there is any history of poisoning, the first thought which should come after ABC is whether this child qualifies for decontamination or not. And I will just come to decontamination separately. Then, is there any disability? And what are the drugs which this child has been exposed to? So I remember a lot of poisonings which have been managed over many years. So drugs which the parents or the grandparents have. Another case of methemoglobinemia which comes to my mind was uh, one of the child took a drug being consumed by the grandfather for leprosy, which he went to the grandfather's room and ingested around 15-20 tablets. This child was only 1.5 years old. Again, severe methemoglobinemia, and we had to treat him with ventilation. After we have thought about decontamination, disability, drugs, we must come to E. E is elimination. Now, can we eliminate decontamination? And second is, can we eliminate this poison? So what are the various ways we can eliminate the poison? I am again going to come to that in a different slide. But we must always do a ECG in the emergency department itself. Because many a times these patients develop a cardiac arrest, not because of coma or not because of hypoxia, but because of the arrhythmogenic potential of most of these poisons and drugs. So we must document that by doing a 12-lead ECG. And one thing which we ignore most of the times is the recording of temperature. But as we have seen, most of the toxidromes, we can fit into one of them only if we do a temperature assessment. And therefore, in this ABC, we must always do a DEF, and F stands for fever. And the only management which we can do actually in the emergency department is, are the three drugs which are dextrose. If there is the patient has got hypoglycemia, we can give oxygen if the patient has hypoxia or is comatose, and in case there is any risk of opioid ingestion or opioid poisoning, because I remember seeing at least 3 or 4 patients with fentanyl patch, the hemat onco patients who had a fentanyl patch on their back, and they came the next day in a comatose state because the patch was 25 milligram patch per hour. These patients were only 10-12 kg. So they were getting around 2 milligram per kg per hour for last 8 to 10 hours. Now you can imagine how much fentanyl was being, sorry, not milligram, microgram per kg. So these patients were being exposed to 2 mics per kg of fentanyl over last 10 to 12 hours. And they all came in coma with hypoventilation. Uh, they were having meiosis, they were having hypothermia, and we had to use naloxone in the emergency department to revive them. So, and it was a prescribed drug. Like the patch was given to them on prescription. So, one must keep that in mind. So, these are the only three drugs which we use normally in the emergency department. Now, coming to the decontamination, the DEF. So we should wash with the soap and water in case there is any dermal or ocular exposure. We must remove all the clothes. We must do irrigation of eyes if there is any spillage of the poison, especially the acids, alkalis, or, or any unintended eye drops. In case of GI poisonings, like ingestions, if the patient comes to us in less than 1 hour, then and then only we can think about decontamination using a gastric lavage. We must also think about doing a gastric lavage for poisons which have no antidotes. And it should be done only in emergency department. Why I am saying so is, if you are trying to do a gastric lavage when the patient reaches the ICU, usually it is the whole process of admission takes more than an hour, availability of bed in the ICU. So what I decide in my setup is that if that thought comes to your mind that this child needs or has arrived to you within in less than 1 hour, then the best place to do a gastric decontamination or a gastric lavage is the ED, because then we don't waste much time and we just start it as part of the emergency procedure. Then coming to activated charcoal, it is 1 gram per kg, and the maximum is 50 grams. It has to be mixed in water, and we have to take around 8 ml of water per gram of charcoal, which means if it's a 20 kg child, we can use 20 grams of charcoal in around 150 ml of water, which is just around 3/4 glass of water, and we can give it. The other is giving oxygen for carbon monoxide poisoning, and then naloxone for opioids, which I've already discussed. And supportive care, as we all know, starting a IV infusion, then checking for dextrose, giving a dextrose bolus, and in circulation, we can give a crystalloid bolus followed by starting of inotropes in the emergency department. So these are the decontamination techniques, only two of them, 1, 2, and 3, and the supportive management, which we have discussed. Now, once we are placing the IV lines, we should immediately take some investigations. And these investigations are the routine ones, and they also work like a baseline, the hemogram, the LFT, the RFT, the electrolytes. Electrolytes are really very, very important because they contribute to the arrhythmias and the cardiac instability which may occur because of these poisons, the lactate level, because many a time these poison they disable the enzymatic systems and lead to increase in the lactate. We must take a urine sample, ECG, and a blood gas, and if possible, a co-oximetry. Then there are always questions that should we do any drug concentrations? Then, though we have availability of so many, availability of these many drugs in which we can check the concentration. But I must share here that we at our setup, we always take 2 or 3 samples for measuring the drug concentrations. And the drugs are the anti epileptics, the paracetamol, digoxin, ethanol, ethylene glycol, iron, lithium, valproate, theophylline, organophosphates, and methanol. So you can take the sample, keep them in the refrigerator, and based on the history or the likely exposure, you can send the blood concentration levels later on. But don't forget to take the sample. Now, when should we? Because only around 10 to 12% of patients need admission, and out of this 10 to 12%, in my setup, I normally keep all of them in PICU because the history is not forthcoming and it is mostly accidental and unobserved that when the patient and how much he has ingested. So first 24 hours, I normally keep the patient in the ICU. So, and what are these 10% of patients who need PICU admission? The short ones are the ones with acute respiratory failure, needing respiratory support or airway adjuncts, respiratory distress, like the one which I showed in my first slide, desaturation. If the saturation is less than 94%, we must always take the patient to the ICU. Hypercarbia, which cannot be measured in the emergency department. Hypoxemia, which can only be measured by doing a ABG. If there is acidosis, if there are features of airway obstruction or ingestion of alkali or acids, apnea or anaphylaxis, because these are the ones who can progress. Even hydrocarbon ingestions, I take all of them to the ICU, or any patient in whom I feel will require endoscopy or bronchoscopy, I take them to the ICU. Then we talk about the circulatory system. Any patient with features of shock, poor pulses, hypotension, need for monitoring, metabolic acidosis, arrhythmias, changes in the ECG, features of failure, hypovolemia requiring fluid bolus, any bleeding or hemorrhage from any site, or thrombocytopenia, anemia, or coagulopathy, especially the hemat-onc patients, I take them all into the pediatric ICU. Patients with GCS of less than 10, patients with features of raised ICP, or any patient with history of seizures, intracranial hemorrhage, irritability, hallucination, delirium, unresponsiveness, serum sodium as done in the ABG of less than 125, potassium less than 3, glucose abnormal ranges, hypocalcemia, patients exposed to intentional poisonings and suicidal cases should all go to the ICU. Patients at risk of multi-organ dysfunction should all go to the intensive care unit. Now coming to the elimination, we have done the decontamination, and decontamination, like I mentioned, should always be done primarily in the emergency department. Coming to the elimination, we have various techniques. One is the whole bowel irrigation using PEG through OG/NG tube, especially in body packers, though not in our setting and in children. But then this is the indication which is mentioned in the texts. And we must continue giving the PEG solution till the time we get 2 to 3 clear stools. Then there are second or third dose of activated charcoal, which can be given in the ICU for elimination, especially if there is history of exposure to sustained release or extended release tablets. So many of these tablets like clonidine or prazosin, they are available in these formulations, which are sustained release and extended release. So one can use uh, second or third dose of activated charcoal, and the repeat doses, it remains 0.5 grams per kg, the dose. 8 ml per gram is the recommended dilution. And then comes the urine alkalinization for especially with salicylates and phenobarbital. 2 to 3 milliequivalents per kg of IV soda bicarb. So what we normally do is use 50 ml of soda bicarb in 450 ml of 5% dextrose with 20 to 40 ml of KCl to maintain a urine pH of around 7.5 to 8.5. And therefore, I would like to reiterate here that we must take a urine sample in the emergency department and do a urine examination there itself. We have various advanced techniques like CRRT hemodialysis for extracorporeal elimination of poisons. And there is another technique which is lipid emulsion therapy for lipophilic drugs and chemicals like tricyclic antidepressants, calcium channel blockers, and cocaine, etc., in which 1.5 ml per kg bolus of lipid is given in a dose of 0.25 ml per kg per minute. So when should we use the extracorporeal techniques? Whenever we think that the exposure is very severe, intentional at times, when the patient is having life-threatening signs like arrhythmias or respiratory failure, absence of antidotes, this extracorporeal technique should be capable of removing the poison from the blood compartment, and it should contribute to total body clearance. Now, there are guidelines, the XTRIP guidelines, and we must have this, volume of distribution of 1 to 2 liters per kg. And if the drug is protein bound, more than 95%, then plasma exchange should be done. And if the protein binding is 80 to 95%, then hemoperfusion should be done. And if the molecular weight is less than 10,000 Daltons, then hemodialysis. If it is 10 to 50,000 Daltons, then hemofiltration. And more than 50,000 Daltons, then plasma exchange. This is given in most of the texts. And in case somebody is thinking of going for CRRT or HD, then one can use this algorithm. Now coming to some antidotes. Now, when we have thinking of antidote therapy, we must see whether the exposure is due to a drug to which we have an antidote available. Is the toxicity lethal? Can we stop the absorption? Can we enhance elimination? And is the intervention hazardous? So we have the recommended emergency antidotes which are available with us are methylene blue, NAC for paracetamol poisoning, naloxone for opioids. Then we have activated charcoal, So desferoxamine for iron, digoxin immune antibody for digoxin exposure. For methanol, we have ethanol. Similarly, we have all these antidotes for various types of poisons, and we must try and keep these antidotes in the ICU so that whenever the need arises, we don't have to run helter skelter. So, atropine for organophosphates. For carbamates, we have pralidoxin. For organochlorines, we have polystyramine. For rodenticides, we have vitamin K. For lead, mercury, arsenic, we have these D-penicillamine is the most commonly used. For methyl alcohol, we have folic acid, folinic acid. For ethylene glycol, we have again the same. For cyanide, we have amyl nitrate. And for methemoglobinemia producing agents, nitrites, nitrates, dapsone, copper, aniline, naphthalene, we have methylene blue. So we have these antidotes for various things. Hypoglycemics, we have dextrose, digoxin, antibodies, INH, we have pyridoxine, opioids, naloxone. For Dhatura, we have physostigmine. For snakebite, we have anti-snake venom. And for botulism, we have botulinum antitoxin. So I'm coming to the last slide of the day is that poisoning and toxin exposures are mainly accidental, 80%, as I mentioned earlier. We must have a high index of intentional poisonings in adolescents. Try to identify the toxidrome. We have a National Poison Control Center. I'll just share the number, which is in AIMS. We must do a thorough clinical examination. Supportive management should be started early in the emergency department. We must see the clinical condition rather than the specifics of the substance which guides the management. Intensive care may be required in around 7 to 8% of patients. It is amenable to preventive interventions, and intentional exposures are associated with worse outcomes. And I must say that the 1% mortality which we are talking about, is usually seen in these intentional exposures. So the last slide is always the the details of the National Poison Information Center, which functions 24/7 in AIMS Delhi. And these are the numbers on your screen. You can take a screenshot, and it is available if you search on Google as well. And they actually guide you where you can get the antidote, if there is an antidote, and also where all the patient can be managed. I've come to the end of my presentation. The house is now open for moderation.
Thank you, Dr. Sandeep. Thank you so much for giving a very, very comprehensive and exhaustive overview of management of poisoning. And Dr. Dhingra has given us a very, very important tips regarding managing poison. If you don't know the exact antidote and not sure what the poisoning is, at least you can do the initial management with management of airway, breathing, and circulation. Where most of children may be saved even if you don't have this antidote with simple measures like ABCD. Now we have some questions in the chat box. Let me see. And
Many of the questions were regarding the difficulty in giving charcoal. So the dose, Dr. Sandeep has already told us, but what people are saying is that when it is given even through RT, then sometimes there is vomiting that occurs. And how much water should be exact? Although he mentioned it, but is there any better way to give charcoal and prevent the vomiting and also make sure that it is administered on time to the patients?
Here I would like to mention that most of these children who are coming to us, in which we have accidental poisonings, are less than 5 years of age. And these children in whom we have to give activated charcoal, we must place a NG tube. and it will help in both in case we want to do gastric lavage. But in case we think that the gastric lavage cannot be done and we just want to give activated charcoal, the best way I have been doing it is by putting a NG tube, mixing this, it forms a slurry kind of a thing, and injecting it because the volume is not much. If we see 8 ml per kg, and these 5 year old child is normally less than 20 kgs. So if the child is around 15 kg and we have to give 15 grams, and 8 ml per kg makes only 120 ml. So it is around 2 syringes, full 50 ml syringes, which we can inject. And if the patient is doing well, we can always remove the NG tube rather than making the child drink the charcoal, which is very, very difficult in a child who's less than 5 years old and who's not cooperative or drowsy. The best way is to put a NG tube and in the emergency department itself and give it through NG tube. Sir, Dr. Suresh sir, how about your experience with charcoal, sir?
Dr. Sandeep sir, please stop sharing the screen.
All right.
Generally, activate charcoal, most of the children take with the NG tube easily. And if the child is sometime fully conscious, you want to give it, sometime you mix it with little coke also to make it little more tasty. If the child is drowsy, then of course we don't mix it with coke. We just mix it with saline, small amount of saline, and give it. But at the same time, remember the fact that we don't have to give, it's for all the participants, that we don't have to give activate charcoal to each and every child with suspected poisoning.
Yes.
The decision to give activate charcoal is like giving an antibiotic to a child with fever. Like you don't give antibiotic to every child with fever. If it is viral fever, you don't give it actually. Same way, if it is trivial poisoning, this is very trivial poisoning, child has ingested 1 tablet of iron or 1 tablet of clonazepam, or something like that, which looks that it will not be very harmful or dangerous, then we don't give it. Only in serious and toxic poisoning we give it. There are some contraindications which Dr. Sandeep has already highlighted. We should not use that in those scenarios like hydrocarbon poisoning and corrosive poisoning. In those cases, it is contraindicated.
Right, sir. Thank you, sir. One important question which was asked even in the chat box is that regarding the making of the MLC. So suppose we also asked this in the group that if there is a small child who has ingested the grandmother's tablets by mistake and has come, should we make an MLC of all these cases, or since we know that it is accidental, should we just let it go? Suresh, sir.
The purpose of making MLC is is there any legal angle involved, right? Or there is something suspicious happening. Making a MLC doesn't mean that we are trying to implicate or say that family has done something wrong. If you think that something wrong has been done at family level, is a homicidal or suicidal, in those cases it is must. Right? And if it is just a trivial poisoning by accidental, it may not be must. But if you are in doubt whether to do it or not do it, right, then you always better do it. If you do it, nothing is going to happen. But if you don't
sir,
do,
totally agree. Yes, totally agree with you, sir. And especially here, I would like to mention that if there's signs, we must always see signs of child abuse.
right.
Yeah.
So
if there are signs of child abuse,
then yeah,
we must
those are
always do it.
Otherwise, sometimes the child takes very small tablet and you say we'll make MLC. With that, what happens? Family get very scared actually. They feel very threatened. कि हमने कुछ गलत कर दिया क्या, हमारे लिए MLC हो रहा है. Will the police will come to our home? है ना? So those kind of things happen. So generally in trivial poisoning, we don't make it unless it's all children who have cardiorespiratory derangement or compromise. In those cases, we always do.
Absolutely, sir. So, as you said, it is important to consider and even talk to family that it is not that it is it's a blame, but it is a process, and probably that's why MLC is needed in some cases. So, one more question is, many people have asked this: Fevikwik ingestion. Suresh sir, in Fevikwik ingestion, what should be done? Is it something which is dangerous or not?
First of all, has anybody really seen the Fevikwik injection?
There are 3-4 questions on this in the Q&A box.
Sir, I think Fevikwik will remain stuck to the lips and will seal the
Right,
lip.
right.
It
So
will
it's
not go
very-
down the
Yeah.
pharynx.
Fevikwik injection, it will stick up in the mouth itself. The only thing it will do is it will bind the tissues actually. It will be less of a poisoning, more of a local injury. And to release that, you may have to take the help of a surgeon, or sometimes we use acetone. Acetone is the one thing which releases this cyanoacrylate.
And one more, sir, more commonly seen these days is hand sanitizer ingestion. So small children, sanitizers are lying around, especially post-COVID. So children are drinking it. So what should be done in these cases, sir?
There may be some hydrogen peroxide or hyperchlorite mixed with that. Because if it's only plain alcohol, then I think it will be just like alcohol poisoning. But if there's a hydrogen peroxide or sodium hypochlorite is there, chlorhexidine can be there. Because sometimes some sanitizers have chlorhexidine also.
Yes,
But some have the isopropyl alcohol also.
isopropyl alcohol.
Yeah, most of them have very, very little amount of antiseptic like chlorhexidine in a very, very diluted form. Even if it is ingested, generally it will not cause any esophageal burn or oral burn. The alcohol part, if it is small amount, right, not much problem. If taken a good amount, then it will be something like alcohol poisoning.
These are so pungent, it will be very difficult to take in large amounts.
Very right.
Yeah,
very
it cannot be taken. So generally, it's a small amount, very difficult to take.
I was also coming to that, sir. The amount consumed is usually a few ml only, sir.
Yes.
Only. This very taste
most
is not
likely
very
these
good.
will have
actually.
local reactions only.
Local reaction.
Local. And best thing is to observe the patient for development of any distress or any features of poisoning.
If needed, they can be hospitalized for 24
and-
hours or something.
24 hours.
And usually in homes, the hand sanitizer bottle is only 30, 50 or max 100 ml bottles. There are very less amount bottle which are, you can keep in the pockets also. But in hospital, the bottle is around 500 ml or 1 liter.
The
So
most
amount,
dangerous thing,
yes.
most dangerous thing is to store, all these chemicals in bottles of Pepsi and Limca.
That used to happen with the kerosene oil very commonly, and
Yes.
sometimes
Yes,
with
yes.
phenyl also.
Phenyl, yes. When the person who's
But
drinking,
all out.
So all out also is one very common.
Yes, all out is very good.
all out again is very common, but and I have personally seen more than 100 patients, but again the volume is so less, and
Yes.
volume is less, and second, hardly they develop any features of poisoning. Even after keeping them in the hospital for 24, 48 hours, all of them recover without any active intervention. So maybe something good is there in that.
In this mosquito repellent, right, there is a chemical called pyrethrins.
Yes, sir.
Okay, which is a natural occurring alkaloid, but now there are synthetic also, which are called pyrethroids. The beauty of this compound is that they can be metabolized by human liver and degraded in a very small amount. But for insects, it's a neurotoxin. So when the insects smell it, right, they develop some kind of drowsiness and they fell down. Though things are getting difficult now, most of the mosquito also have developed some kind of a resistance to all this. They keep on flying even on all out. Small amount, again, not much problem, but if some child takes a very like 5 ml or 10 ml, right, then it can have neurotoxicity. Licking little bit of half ml or 1 ml may not cause problem, but 5 ml plus will cause neurotoxicity. They will become drowsy. They can have seizures. And there's no antidote. Management is, of course, supportive only.
Supportive.
Leaking used to happen with those tablets. Initially, it used to come in the tablet form, like which
Yeah.
used to rinse. But with this, they can drink small amount. But
Yeah.
again, taste being so bad.
So one more question was about methylene blue. G6PD, it is contraindicated. So in these cases, then is there an alternative or what should be done? Suresh sir.
Methylene blue, when the child comes to us for the first time with a methemoglobinemia, right, we don't have any G6PD level, frankly speaking. And that level may take few hours. So
And
time is a
it can be
very,
unreliable also, sir.
and we don't want to wait for the G6PD.
Yes, sir.
So one dose definitely you can give. No, it's not going. Multiple doses are the one which may cause problem. Those who have got G6PD deficiency. And again, that depend on the level of G6PD deficiency. If it's just a milder one, they may tolerate it. If it is severe deficiency, then other alternative is your exchange transfusion and other things we do.
Yes.
Yes, sir. Thank you so much, sir, to both of you. We actually have plenty of questions. We've tried to take up the common ones, but I think for lack of time, we will not be able to complete the rest. Over to Dinesh sir and Dr. Ajay sir for the closing remarks.
Yes, wonderful session by Dr. Sandeep, and he's just an expert in this poisoning field. And the main aim of this understanding is that how to minimize the effect of a poison. So by removing the subject from the site, and then using antidote, and then to prevent the side effect, and then follow up the cases in the after discharges also. So it's wonderfully covered by Dr. Sandeep sir, and nicely moderated by Dr. Veena and Dr. Bharat and Dr. Suresh sir. And I think it will enhance the knowledge in the field of poisoning to each and every delegate. And the purpose of these classes are just to disseminate the knowledge to the candidates so that nothing should go wrong, and we should follow the protocols, and we should aware of the common poisonings.
Hello. One more information that we'll be launching gastroenterology module shortly. So I request all delegates to please register for that also. And we are having pediatric conference of North India in 26 on 20th and 21st June. So we'll be sharing that flyer. So please register for that. And the central IP elections are going on. We have certain candidates for the central IP post from Delhi. That is Dr. Anurag Agarwal for Joint Secretary Liaison and Dr. Alok Bhandari for Treasurer. So I request all of you to please cast your vote as early as possible. Thank you very much. And we'll be seeing you all next Sunday. And we are really thankful to Dr. Sandeep Dhingra and Dr. Suresh Gupta sir for a wonderful discussion. And thank you, Dr. Veena, for moderating this session.
Thank you so much, sir. And thank you, IP Delhi, sir, to give me this opportunity. It was really a wonderful session, sir. Thank you so much.
Thank
Mr.
you.
Sushil,
Welcome.